Alright everyone, welcome to Hematology. This is a lecture intended for medical laboratory science students. We are going to be talking about the CBC and the peripheral smear. So if you have Rodex, Hematology, the listed chapters are at the bottom there. So there's sort of two important things that as lab techs and doctors are potentially looking at, right? Is the CBC and the results that lab techs gather from the peripheral smear. Well, it's really important that the peripheral smear is good because what we judge off of the peripheral smear will help provide a lot of valuable information regarding a patient's health and current status. If the smear is not well made, then that will affect the RBC and the white cell morphology for the negative, as well as any platelet and white cell estimates that you might perform on the smear. And usually it's the first skill that a lot of hematology labs like, especially new grads, to master as soon as they enter in the lab force. A lot of larger hospitals will prefer doing automated, but it's good for you to know how a good smear is made. Also, what we report out from the lab is called the CBC, or the complete blood cell count. It's a general screening test that will report out the white cell counts, red cell counts, and platelet counts, as well as the RBC indices and cell differentials that will provide a lot of information to the doctors. It's one of the most commonly ordered tests. I believe at my hospital, it is the most commonly ordered test. Um, it's a really important tool because when you look at the CBC and look at the patient's um, symptoms and physical health as well, then that will provide a lot of clues for the doctors to help move towards a specific diagnosis. The CBC is only ever ran on lavender tops, except for one special little exception, which we'll talk about in a slide about troubleshooting. So the CBC primarily is done by automated these days. I have a lecture that talks a lot about the manual um, methodologies, but we're just going to focus on the automated, and this is primarily how most labs are done. So we use instrumentation that helps determine the different parameters of the CBC. So these are measured by impedance and optical light scatter. So impedance is when it's also called the Coulter principle. It's when cells are forced into a single file line in between these two apertures, or in between these two electrodes. What happens is that cells to go through, they stop or impede the electrical current. The strength of the resistance or impedance will determine the size of the cell. It can count 10,000 cells per minute, but the thing is that it can only really count the number and size of cells, but it can't distinguish between any cells that are similarly sized. And a lot of the issue is that a lot of our granulocytes, like eosinophils, neutrophils, and basophils, are all similar. Um, so this is a really simple way to count things, and if you're just looking for a count, then this is what you'll use. But there's a little bit more advanced technology. So flow cytometry refers to when cells are passed through a single file line. As it passes through, you can attach markers to each cell, though usually this is done before they pass through. These markers will bind to specific markers or proteins, like antigen, CD markers, etc. So what happens is light passes through the cell as they pass through. Light will also help excite any fluorescent markers, causing them to glow or fluoresce, as well as the light will scatter based on the inside of the complexity of the cell. So let's say, for example, you have a red cell, which doesn't really have a lot of things for light to bounce off of. So light will be over here. Sorry, that's a little difficult for anyone to see. And it'll shine through the red cell. Or we can also have this nice little white cell here. They're normally not this red. So based on the inside of what's inside of the cell, light will want to bounce in different directions as it's passing through these different granules. So any granules will cause light to scatter off to the side, and the sides of the cell will cause light to scatter forward. So then we place these detectors in front of and off to the side of the in front of and off to the side as it detects light scattered. So then we can plot out the intensity of the forward and side scatter onto a scattergram. And this is what the scattergram on um, based on Sysmex will look like. So the instrument will measure populations based on their positions on the scattergram. You as techs, fortunately, will not have to do this, but you do have to understand generally what this means. So I believe the top or the y-axis indicates size. You can see that SFL there, that stands for forward light, and the side there, which stands for the side scatter, which is the granularity. And the instrument will be able to help determine the populations of each based on where it falls within that graph. The degree of separation from each population slash color will also help determine the accuracy of the scattergram. What we would like is just these really nice and neatly grouped far apart cells from one another so that way we're confident in what we're looking at is accurate. You can also combine this with fluorescent markers, which will allow flow cytometry to become highly accurate and highly specific, except for some cases, but we'll talk about that a little later. Flow cytometry is also used outside of hematology when we're talking about immunology or genomics. So, if you are a lab tech, this is going to be generally what the reference ranges look like. For the AACP, there's not a lot of reference ranges that they want you to memorize by heart, but the CBC is usually the one that they expect a lot of students to understand when they take the boards. So, yes, it may vary in number by a little bit, but as I've told my students, if there's one thing to go off of, if I had to pick one set of reference ranges for you to memorize, then it would have to be the CBC. So the white count, red count, hematocrit, hemoglobin are all done via automation, at least nowadays. So the units for the white cells is billions per liter, red cells is trillions per liter. Hematocrit is usually reported out as a percentage, but you can occasionally see liter over liter. Um, and hemoglobin is usually reported out as either grams per deciliter or grams per liter. We also need to take in consideration as lab techs what we call the rule of three, which is that the RBC count minus unit times they should equal the hemoglobin. Hemoglobin times they should also equal the hematocrit. All three of these need to follow within a reasonable amount of the measured value. If the values violate this rule, then we have to start thinking about is there some sort of issue with the measurement, instrument, or with the patient themselves. So the indices help doctors figure out what the actual cell looks like. When we report out the RBC morphology, we can use general terminology to describe it, but usually, most likely than not, most people prefer hard firm data. So the RBC indices is to help portray that as hard firm data. So we have three primary indices. First is the cell volume. Next is the mean cell hemoglobin, which only measures the concentration of hemoglobin overall. And last but not least is the mean cell hemoglobin concentration, which basically corrects the hemoglobin concentration in relation to the MCV. So if mean cell hemoglobin just measures the amount of hemoglobin overall, mean cell hemoglobin concentration measures the amount of hemoglobin per cell. By using all three of these indices together, that will help doctors get a firm idea as to what's happening with the RBC morphology, and it'll also help you as a lab tech help see whether or not what you're about to report out on the RBC morphology is accurate or not. So the importance of this is that you can classify anemias and diseases, or you can figure out if there was some sort of instrumentation issue. You have to figure out before you report it as if it was a patient condition, that you have to make sure that there is no technical problems that could help give that would give false results. So you should know the three indices, what they measure, the reference ranges, how to calculate, etc., to be able to help figure out if there were any technical problems in the measurement of the CBC. So the mean cell volume, it's again the general average size of the RBC that's expressed in picoliters. So that could be calculated directly or manually. The reference range is about 80 to 100%, and as a student, you need to get comfortable in using this terminology. Any cells that fall within that range we call normocytic. Anything that falls below the reference range or 80 below is called microcytic. And anything that's greater than 100 are called macrocytic. And this is what you should be getting used to calling on your RBC morphology as well. Abnormal MCVs can help indicate all sorts of diagnostic issues, and what direction you're looking at will help to indicate what kind of anemia you potentially be looking at. So that's the MCV calculation down below. If you're my students, then you have to learn the all the calculations that I'm going to show you. The mean cell hemoglobin, it's just the amount of hemoglobin that's found in one RBC. Its units usually picograms, and it can be calculated either automation or manually. The research range is about 20 to 34 picograms. Again, it doesn't really take into consideration the size of the cell. It just tells you how much hemoglobin is present in that one cell. So on its own, it's not exactly super helpful. But generally speaking, it has a direct linear relationship with MCV. So usually if you have a large MCV, then you should also have a relatively large mean cell hemoglobin as well. And down below is the calculation. So this is what helps correct for the volume of the cell. So it's measured out as a ratio of hemoglobin mass to the volume of the RBC itself. Um, so again, this can be done automated or manually, and the reference range is 32 to 36 grams per deciliter. And it's really important to help determine the chromicity or the amount of hemoglobin in the blood. Um, so let's start with normochromic, and this is about a normochromic cell. That's basically where the central pallor or the clearing inside of the cell is only about 1/3, which is about normal. That's what we expect. If that central pallor is much larger, then we call that hypochromic. If it's lacking a central pallor or it's super highly concentrated, then we call it hyperchromic. Rarely will you ever see a hyperchromic anemia. I think a lot of textbooks will argue, like even though spherocytes are technically hyperchromic cells, would argue that they would not be appropriately called hyperchromic anemias. If you prefer your root words, hypo less than chromic color less than color. Normo normal color. Lot of or high amounts of color. And this is just a really nice summary slide here. Again, if you're looking at something above, if we want to talk about in relation to the reference range, if it's less than 32 grams per deciliter for the MCHC, then we're expecting a hypochromic cell. If we're seeing a greater than, then we are expecting a hyperchromic cell. If it's not matching up with any of these, then we got bigger issues. And again, I'll talk about this in a troubleshooting lecture. So the RDW is the way that we measure the different ranges of cell within the RBC. And it's really helpful to indicate whether or not we're working with a dual population in the patient, especially if they had a blood transfusion. So this is so almost like where we're going back to basic stats. If we're going to call the MCV the average, then the RDW is the range. And it'll give a better idea of to tell the doctor how large the distribution of size is within the patient. And that could also be a helpful indicator clue rather than just getting the mean cell average. If we have an increased RDW, then we're working with a lot of different sizes of red cells. If it's within, then we're looking at regular, about the same population sizes. The reference range is about 12 to 15 degrees, and knowing whether or not you have a large RDW will also provide a lot of important diagnostic clues. So this is a really nice representation of RDW. Below we have charted the RDW. And what we're looking for, if it's a uniform population, like in the left-hand side, we're looking for a relatively small distribution. But on the right-hand side, we have a whole lot of different cells here. Some are very small, and some are very, very large. And when you see that red line in between the peaks there is so much larger on the right-hand side than it is the left. Platelet count and MPV. So platelet count is reported out as billions per liter. MPV represents the cell volume. So you can use the combination of both to help assist in any sort of coagulation disorders. A low platelet count can represent decreased amounts of thrombopoiesis or increased platelet destruction and consumptions. Increased platelets can be seen in any reactive or malignant conditions. For example, like sickle cell will have a high amount of platelets. MPV will also allow physicians to see whether or not we have giant cells, and those are usually found in a bit more rarer disorders. So we're going to talk about the peripheral smear itself and how we use the counts that we were just talking about that will help impact any blood smear evaluation itself. So usually the wedge smear, I've only ever seen variations of the wedge technique, is by far the most common method that you'll see to make slides for a peripheral smear. So what you do is you just take one drop of well mixed blood and you pull that blood across another slide by using another slide to push this all the way across. You're generally looking at about 30 to 45 degrees, depending on the patient's hematocrit. The movement needs to be very quick, very smooth, and with just gentle pressure. You don't need to slam your whole body weight down onto the slide. And also, while you're making the smear, is that the blood drop will spread across the slide that's spreading the other slide. So what I was talking about where you can have this variation in angle will depend on the hematocrit. If you're working with a higher hematocrit, then you want to move to a lower angle. That will allow the length of the smear to increase. If you're working with a low hematocrit sample, then you want to push it at a higher angle to help shorten the length of the smear. And it again all depends on what you're looking at. Most hospitals, I believe, especially when they're large volume, will prefer you making smears automated. But, excuse me, in smaller hospitals or labs that can't afford the extra space to have an automated machine, will also expect techs to make slides or smears manually. So this is a really nice image graph here. So what they're doing is they're taking one smear that's positioned at the bottom using their left hand, and they're taking a different smear and pulling it back at about 30 to 45 degrees in between here and there. And what they're doing is that drop of blood will spread across the entirety of that slide. Then in one smooth motion, you're aiming to get across a good length of the smear. You don't want it too short because that means you're going to end up with too thick of a smear. And you don't want to end up too far because now you're just working with a lot of empty space. Also, this is important for anybody who's working with an automated machine. Some automation especially stuff like the television, the computers are designed to only read at about 2 to 3 thirds, or two thirds of the smear midway through. So if it's too short, too far, then it won't be able to pick it up at all. So again, 2 thirds to 3/4 is about where you want to land on. If you're working with the television, then you really should be aiming for 2 thirds. Oftentimes what you'll see is that it's this slightly rounded feather edge, so you don't want it to be a peak like that, and you don't want it to be flat like that. The reason that we want it to have this slight curve is that it allows us to have a much larger surface area for the peripheral smear without it just being completely inaccurate. Also, what we don't want is that we could see the edge of the smear, but we know that we haven't put so much blood that it's now just leaking off to the side. The film should be smooth without irregularities, holes, or streaks or tears, so we're looking for this really pretty smooth gradient. If you're seeing a lot of dots or these specks on your smear, then that might indicate your slide's a little dirty. Also, and I didn't really realize this, is that the thin portion of the feather edge will often have this rainbow appearance, especially if you did it just right. So these are all pretty good examples of pretty bad smear technique, and a lot of what happens correlates to what could have happened here. Um, But generally, you want this nice shape so that way we can get a good feathered edge to read off of. If I told you to pick a feathered edge off of like this one or this one, then you wouldn't be too happy with me, if especially if I presented you with any of these smears. And I would suggest getting used to these just also from a technical standpoint, so that way you can help troubleshoot what happened when you're making your peripheral smears. You should also dry your smears, especially if you're working with bone marrow, which is a lot more viscous. That way you could avoid any drying artifacts, especially as the RBCs become crenated. Um, so this is sort of a big thing, and I don't think I've ever seen anybody encourage this yet, and hopefully I don't. But you really should not be blowing on your slide. When you breathe out, you cause a lot of moisture to escape from your mouth, right? And when that happens, that moisture lands onto the slide. And what happens is that these echinocytes start forming of these crenated cells, or you have some sort of weird artifacts that you see on your smear as well. Generally, your red cells, for some reason, will look slightly less stained than others in different parts. Also, it's just gross, and you don't want to do anything gross in the lab. Our specimens are gross. You as a person are not. So after you make a good smear, then you quickly dry it, then you have to properly stain it. So the white Gaminsa stain is by far the most common stain that you'll see in the lab. Usually, and depending on manufacturer, will have a combination of ESNY, methylene blue, and methanol, as well as other buffers and rinse solutions. But the ratio is usually proprietary and will depend on the manufacturer. Methylene blue is a basic dye, and that will stain any acidic components to this like blue purple color. So basophils will appear really blue. Nucleic acids or nuclei will look blue as well. ESNY is acidic and will stain any basic components to this sort of red and pink color. For example, eosinophils and hemoglobin. Understand that because we're sort of working with a lot of pHs here, we want to make sure that the pH of our reagent, our stain, and our smear are at the right pH. You really should be performing this over a dirty area. If you have worked with these stains in a sort of academic setting, then you know how intensely they will stain things. So you really should be working in an area that you're okay to get dirty. After the smear has completely dried, then you should flood, then the slide needs to be flooded completely in sort of the sequential and timed order. We're looking about at 1 to 3 minutes. And what'll happen is you'll notice that these smears produce this slight green sheen, and that will show you that you have a good stain that you're working with. You shouldn't be seeing just blue. Then you obviously have to get rid of the stain, and usually that's done via dipping in ethanol. For high volume labs, we need to have automated smears. I work at a high volume hospital, and the amount of CBCs that we get, which could be about 10 to 15 within just a 10 to 15-minute span. If I had to make smears manually for every single one, I would be crying. So we have automated smears for this reason. Um, Once you're able to set it up, load it up with slides, then stains will just happen without you having to manually time it. In general, it takes about 5 to 10 minutes depending on how your stainer works. And some slide makers will also automatically make your wedge smear as well. What we're looking for is a good color in our smear. So these are all characteristics that you should be generally looking for while you're looking at a smear. So you're looking about salmon pink. I wouldn't argue that they would be orange. You're looking at a good nuclei color where it's blue and purple, but it's not fading into the background. Neutrophil cytosols will usually actually appear almost like red cells. They should be a similar-ish colors, with these like gentle violet and lilac granules showing through. Eosinophils will be very easy to notice. They should be bright orange with these granules that almost look 3D. If you're looking at a bad stain, it will affect your judgment a lot based on what's like looking at one cell that you're looking at. You might be tempted to call an eosinophil a neutrophil if it's not stained that well, or vice versa. So you want to make sure that your smear is really accurate and properly prepared. Otherwise, somebody's not going to be in for a good time. So these are examples that I've taken from my hospital, de-identified patient samples, of course. So the left side, we're looking at these bad smears. You can even see the stain artifact there, and actually down there too. But you see how the red cells don't even stand out? The the nuclei and the cytoplasm of like these lymphocytes are pretty good, but this neutrophil is straight up fading into the background. I would cry if I had to read these smears. Same with this guy. This is not really properly stained, and even though with experience you can build up the ability to read off of poor smears, this is really not the ideal. The right side is really what I want to be looking at. So my neutrophils have this really nice variation in the granules. I could see some more lilac granules here. Those might be Dolly bodies actually. The nucleus is really nicely contrasting with my cytoplasm. My red cells are really nice pink. My lymphocytes look actually blue, and I could tell where the cytoplasm ends. My monocytes actually look different than my neutrophils, which is usually an issue with poor smears. And you can also see my eosinophils look 3D right here. I can literally picture each granule inside of it. So these are characteristics that you want to be aiming for. Is just this really well developed color, especially cells don't look like they're just about to fade into the distance. So if you're noticing that your red cells are looking gray, your white cells are too dark, or your eosinophils are not pink, then your stain and buffer might be too alkaline, or you have inadequate rinse cycles, you're staining it for too long, or you're actually not working with an EDTA sample. If the stains are too pale or too red, then and the white cells are barely visible, then your stain or buffer could become too acidic, you're underusing your buffer, or you're over rinsing. Also, I want to add a additional bullet point here. Smear is just old. The examples that I had on the left there are actually teaching smears, or teaching slides that we use. And each time they run through the cell-o-vision, we notice they get a little bit worse each time. And that's just because the stain over time won't hold as well as you initially did them. But generally, you can try to restain the smear to help fix it, but you would have to get rid of the original stain and then restain it, and that might cause more issues than if we were to just try to read off of it. So when we're going through the scope, we're sort of thinking about a few things. We need to, in order to be able to tell what our red cells actually look like, we need to look in the right area. So what we're looking for is the RBCs that are really well spread out. Few can be touching, few can be overlapping, but not that many, and they look about as normal as you can get, with especially with the central pallor. If an area is too thin, then or there's holes in the film, then the RBCs will look flat, large, and distorted, and you don't want to call anything that you don't want to call it. And if you're looking too thick, then that will cause the RBCs to look like rouleauing, which is not true. RBCs can also become similarly distorted, which makes evaluations or manual differentials really difficult to do. When you find the right area, then there should be about 200 to 250 RBCs per high power. So the left there is too thin, and you could tell because, or the left there is too thick, rather, and you could tell because all the cells are stacking up on each other. And yeah, you can see rouleauing in an area that's just right. But I can also tell because the RBCs look really distorted. They don't look like regular cells the way that they should be. On the right is too thin, and you could tell because they just don't have a central pallor anymore. They also look really large and really spread out. The bottom there is what we want. So I would argue this is even just a touch too thick, but you can see that you can see a nice, the cells look about as normal as you can get them. You have a nice central pallor, and it looks just right. So in order to prevent doubling back on yourself or going, wait, did I count this area already? And preventing inaccurate counts, you need to make sure that your search pattern is consistent. I know some texts they have their own thing, but for the sake of it, I'll teach you the standard way. And usually the best way what you'll do is you're gonna go in this battlement pattern here. So all you're doing is just zigzagging back and forth through the slide as you're moving to the right. You don't want to move just up and down because all you're going to do is just count the same area over and over. You want to start from the left, move up, right, down, right, down, and etc. like that. The reason that you would want to do this is you want to count 100 different white counts to help determine the relative distribution of the white cell types. You can also use the RBCs to help assess them for quality. So just kind of generally checking through to see what you have. So you're going to get your first impression on low power. So you could tell the quality of the smear, what the general RBC cell distribution and white cell will look like. This is also a good time to see if there's any sort of weird issues that might cause some sort of collection. So you can see fibrin strains on low power. You might also be able to see platelet clumping. You can also see if there's any sort of agglutination or reloading, and you'll know that it'll be real because you know you'll be looking in the right spot because every other RBC looks normal, but all of a sudden things are clumping up together. You can also check the feathered edge or the what my senior tech likes to call the gutters to check for platelet clumping. Then you're going to want to increase your power. So at the 40x, this is a good place to do your white cell morphology. The reason that we recommend that you do it on high power is so that way you're not overthinking the individual characteristics in a cell. So you're going to want to start near the very end of the feathered edge of the slide. Again, you want RBCs to just nearly touch but not overlap. Um, and you'll scan through that feather smear that way. You could also perform a very quick white cell estimation on the 40x. All you do is you just have to count 10 fields. Within those fields, you need to count the number of cells. You take the average, you don't multiply it by 2,000, and you can get a rough estimate that way. Then finally, you move to the oil immersion. So this is sort of a disclaimer about white cell estimate. There's a reason why we call it an estimate. We can't call it a firm count because we have no way to firmly say that this is indeed an accurate count. So Most labs will report out a high, normal, or low. You can also use a white cell estimate to determine if any NRBCs are affecting the white cell count. So this is just an example down there, but basically you're just taking the average, multiplying it by 2,000. Then you're going to move into the oil immersion. So this is the highest magnification, and but you need oil to help reflect light more accurately. If you try to do an oil lens without oil, you're going to learn very quickly why you don't skip the oil. I know a lot of techs will do it on the 100. I believe usually the standard is that people will swap between the 1000 and the 40 to make sure that they aren't overthinking the cell characteristics. So when you're doing a white cell morphology or manual differential, excuse me, you're thinking about these few things. First is the total white count. If I'm looking at the smear and it says that I have a high white count, then I need to anticipate a high white count. If I have a low white count, then I need to anticipate a low one. Um, then what I'm going to do is I'm going to count the type of cell that I see. Um, so if I see one neutrophil, I'll count one neutrophil, two neutrophils, three neutrophils, etc. What that'll do after 100 cell is it'll describe the amount of cells I counted into these percentages or relative counts. I can then apply the relative counts to the total white cell count to get the actual number or the absolute count of each type of cell. And last but not least is I'm also going to perform the morphology of the cell itself. If there's any sort of abnormal inclusions, then doctors will want to know that as well. So the Cell-O-Vision is by far the most popular morphology system that you're going to see. What's it going to do is basically it does the job for you. So it's going to go to the feathered edge and it's going to take pictures of each of these cells on a microscopic level. Then it's going to display it out into the computer screen there that you see on the right. And that allows us to just do a manual differential so much more quickly than if we were to have to take the time to go calibrate, find the feathered edge, and then go through and and we'll have to just do the whole thing from scratch. All I need to focus on when I'm doing this television is making sure that the correct cell is in the right category. I can confirm it. I can confirm the automated count. I can do a manual differential from here. Cell-O-Vision is just really nice to have when you're working in a heme lab, especially at a high volume. Though you won't see Cell-O-Vision at every hospital, it really does depend on the hospital's needs, ability to house it, and the time and cost it takes to establish it. So now we're going to talk about the RBC morph. So this is what we talk about after we usually do a white cell estimate or differential. Also to under Also, I just want to make a quick point about automated and doing manual differentials is that you have to take into consideration the characteristics of the cell. If you refer back to my white cell development lecture, then I talked to you about what the general characteristics that I'm looking for as a lab tech when I organize cells. So, RBC morphology, I know textbook likes you doing it at at 100 times objective, but usually text will go one further back, usually about 40, so that way you could see the RBC cells as a group. So what you'll see a lot of people, especially in my lab, do is they'll have the CBC up on the screen while they're doing the RBC morphology. The RBC or the CBC will help inform the RBC morphology and vice versa. What I'm trying to do is making sure that what I'm reporting is similar or accurate to what the CBC says. If me and the CBC are highly disagreeing, then something's going on. I'm also providing additional information, like if there's any RBC inclusions, or if I'm noticing any sort of anestecytosis, which is a wide distribution in the range, or a large number of abnormal cells. I can also take this opportunity to evaluate for NRBCs. Most automation will automatically correct for the NRBC, but if I need to do it manually, then I need to follow my SOP to see when the manual calculation is needed. But generally down below is what the correction count will look like. So again, red cells are what we're looking for is a biconcave blood cell. On the microscope, it looks like a donut. Usually the reference range on the MCV is 80 to 100. If you're measuring it on the scope, then it'll look about 7 to 8 micron meters. Some scopes will have it inbuilt on the lens, but it really depends on your hospital. MCHC will also help me describe the central area, though it can also be microscopically evaluated. Um, Again, I've emphasized this in previous lectures if you look back, but this does not mean it's hollow. What's just happening is that this area of the biconcave disc is so thin that light just passes through. If there's less hemoglobin to fill up the cell, then that causes more of this central pallor to appear than it would normally. And again, we're looking about 1/3 of the diameter of the cell to call it a healthy central pallor. So this is a general rule that I see a lot of people using. We're going to use a small lymph nucleus. So a red cell should be about the same size as the nucleus of a small lymph. If you notice here that a lot of these cells are much smaller than the nucleus, then we're going to call it microcytic. And this is sort of a general rule, but you can only use this rule if, one, you can find a good example of a lymphocyte, and two, if you're looking at a small lymphocyte in the first place. I don't want to take an atypical lymph. Actually, the nucleus is going to be a little bit larger than that. I don't want to take an atypical lymph whose nucleus is expanded and use that to compare the red cells around it. If you notice on the top right there, and actually this left here, we have a lot of cells that are much larger than that small lymph there. So we're going to call that macrocytic. Again, you want to make sure that the lymphocyte you're using for size reference is a good lymphocyte to use in the first place. So neocytosis just sort of describes that whether or not there's a large variation in red cell size. The RDW is automatically done, but you can also call it when you're looking at the RBC morph. Usually when we talk about the RBC morph, we'll grade it. So 0 meaning it's not present at all. 3 means that it is everywhere in this slide and it's a noticeable degree. Anything in between is a bit more subjective than that, but that's generally the guideline that I see most hospitals using. Again, anesthetiosis describes the RDW. It does not describe the volume of the cell itself. So if we have a large amount of anesthetosis and a large RDW, then that means different sizes are present. And that could be due to a lot of different things. Again, I should be comparing my RBC sizes to not just the normal lymph, but also to each other to see if there's a large distribution of sizes. Poikilocytosis just means there's different shapes in there. To the degree of which is usually depends on the hospital. But some shapes and sizes are characteristic due to some sort of hematological disorder, and some morphology may be actually artifactual, which will usually be caused by poorly made or improperly stained smears. Hospitals will pick one or two systems, but they both mean the same thing. If one is very rare, and 4+ means it's very bad or very severe. Hospitals will usually pick one or the other. They're not going to do a combination of both. So these are what we're going to go into in a little bit. But if you like tables, then this is a really nice thing to refer back to. podocytes that's being shown on its side, it'll look a bit more like this. Imagine that outer rim is completely filled in. Some of these are a bit more 3D than I like, and it doesn't really help show you what you're looking at on the smear, but again, we'll go over this. But these are good. These is a good table to go back over. It'll also show you the common name versus the formal name, and you need to get comfortable between swapping between one or the other. It'll also show you the causes as well, and some of these shapes are a bit more commonly called than others. Um, these are actually really nice cells. These are RBCs that are usually strongly associated with some sort of disease, especially hemoglobin C, sickle cells, acanthocytes, schistocytes, teardrops, or hemoglobin SC. We also have our inclusions down here, which I've talked about a few times in others lectures. So acanthocytes, if you like root words like I do, acanth means, I believe, spear or thorn. Cyte just means cell. So we're thinking thorny cells. So they have these really spiky projections that come from the inside of the cell, and this is usually the how extreme those spikes are tells you whether or not it's going to be a burr cell or an acanthocyte. And usually what happens in an acanthocyte is that you have some sort of altered lipid content on the membrane. So if you have an increased cholesterol, then that will cause increased permeability or fluidity, and that will cause these spikes to form. This is usually a cell that's usually strongly, especially seen in big amounts. You're looking at liver disease, adolipoproteinemia, or splenectomies. If you're looking at codocytes, my student was able to find this for me. Codo meaning bell, because on from the side it's supposed to look like a bell, but more commonly you'll see target cells. On the smear, they're going to look like a target because you can't see things from the side. And usually these target cells can be associated with a lot of different diseases. So you could see them in any sort of any diseases that are associated with membrane lipids. So that's usually liver disease. Or if you're looking at decreased hemoglobin, like in IDA or thalassemia, or in any hemoglobinopathies like sickle cell. Darkocytes are just cells that have one long spike coming out of it, and this will form because if it's pathology at least will form from the RBCs squeezing through the fibers found in the bone marrow or the splenic cords. Real darkocytes will be facing in different directions. Artificial darkocytes will be caused by one direction, and that's usually because you applied too much pressure to the slide. So notice that these darkocytes are going in different directions. There's other examples of cells too, but that's how we know it's real. Trypanocytes or sickle cells. These are really fun to see. So there are RBCs with unique that just look like a crescent. They also are called sickles because they look like sickles. So what happens is that there's an abnormal hemoglobin with an inappropriate amino acid substitution. For anyone who's really nerdy, then I would really suggest learning the asterisk at the bottom there. What happens is that that amino acid configuration can't really cope well when you go through low oxygen environments, decreased pH conditions, or even when it's just cold. So what happens is that as it squeezes to the small space, it can't pop back into its normal form, and that sickle cell will start getting stuck to each other because if you look at it, it's very sharp, very spiky. So it can also cause clotting, not just clotting, but also cutting up the blood vessels on the inside. And that's where the hemolytic anemia part of sickle cell comes in from. You can also see some sickle cells are able to be reversibly sickled. Like this guy here, he's not so sickled that that he'll be able to pop back into shape. This guy won't. Important thing to note is that you'll only see sickle cells during a sickle cell episode, and you'll talk more about that in advanced team or in any other lectures regarding hemoglobinopathies, but just understand that it's strongly associated with sickle cell anemia. And so this is where that shape comes in. It's You can see how this is a nice sphere or round object that can go through a tight space. Sickle cells literally just get caught because of how spiky it is. And this will cause a lot of joint issues, especially. You'll see this as a big problem in sickle cell patients, is that they'll complain often about joint pain, and it's because this awful mess is happening to them. Echinocytes, echidna, think like the animal, and cytes, or they're also called burr cells because they look burry, or like these gentle burr-like projections if you ever had to deal with a burr seed in your backyard. So the thing that I was talking about with acanthocytes, where you're looking at something that's very extremely spiky, burr cells don't have that extreme spikiness. They look a bit more fuzzy. Echinocytes might happen due to making slides poorly, um, especially if you have some sort of issue with your methanol fixative. You could also just do a quick check through the blood by just checking it on the smear if it looks real or not. True echinocytes are usually related to the outer lipids that are found on the RBC membrane, and that's usually associated with stuff like uremia, liver disease, or PK deficiencies. So this is what echinocytes look like. They have these really gentle projections here that are found throughout the cell. Acanthocytes will be a much more extreme like this. Also, they look like little echidnas. Elliptocytes. I hear them as pencil or cigar cells, but generally they're just very long ovals. Usually that'll happen because there's some sort of alteration in the skeletal protein that causes it to not be able to come back to normal, especially after it's squeezed through the capillaries. You'll see this strongly in hereditary elliptocytosis, but also in thalassemias and iron deficiencies. Ovalocytes, I believe, are similar to elliptocytes. It's just less extreme. Um, but you'll see, depending on the institution, some institutions don't care for the difference between elliptocytes and ovalocytes. It really depends on your SOP. But if you're looking for the boards, then they consider these two separate things. You'll see ovalocytes in hereditary ovalocytosis, thalassemia, and IDA as well. So it's just basically a difference of how long is your cell. Elliptocytes are a lot longer, a lot skinnier, and ovalocytes are a bit more like a regular oval. Schistocytes, jokingly called schistocytes by everybody who works in the lab. They're just general cell fragments that may be caused due to mechanical destruction. They can just sort of called, um, they just have any shape that they want. You could look like a triangle, you could look like a helmet, you could look like a comma, whatever you call them. And they usually are a lot smaller than the rest of the cells that surround them. Schistocytes are not really meant to live for a long time, and you could generally figure out why. Usually, schistocytes will usually be culled by the splenomegaphrages or just burst on their own. If you see a high amount of schistocytes, then that will be associated with microangiopathic hemolytic anemias, heart valve hemolysis, DIC, severe burns, or intravascular damage. And schistocytes can do whatever they want. These are just a few goofy examples. You can see a whale, you can see a goldfish, you can see a duck, you can see a rabbit there. It's whatever they want to be. Keratinocytes or helmet cells will basically look like a helmet. They have a thick middle and thinner ends. They're usually formed via fibrin strands. So basically, what'll happen is a fibrin strand will form, and the RBC, as it passes through, it just kind of slices it in half. So it's usually associated with microangiopathic anemias, heart valve hemolysis, Heinz body hemolytic anemias, or glomerulonephritis. Spherocells. they just look like circles. They don't have essential pallor, then they'll usually end up looking smaller on the smear, but the MCV is usually ending up being normal. You'll see some institutions calling them hyperchromic because they usually have an increased MCHC. But the thing is that spherocytes are not very good at living, so they have an increased osmotic fragility. When they have an increased osmotic fragility, that'll lead into increased autohemolysis. They're less deformable than your biconcave disc or your discocytes, and that leads to a decreased lifespan, and they're usually removed by the spleen. You'll see it in hereditary spherocytosis or immune hemolytic anemias as they're being destroyed by complement, and they straight up look like circles. I was not joking. Stomatocytes. Going back to our root words, stoma, mouth. Stomatocytes just look like lips. So instead of a nice circle, you're gonna look at this very oval central pallor. You'll hear them being called mouth or lip cells. The shape of this is reversible, and it's usually an increase due to the inner lipids that are found on your inner membrane, and is associated with hereditary stomatocytosis, spherocytosis, alcoholic cirrhosis, lead intoxications, or any neoplasms. And they look like lips. So this is sort of a general tip, is that some findings are a bit more clinically significant than others. If I call a burr cell at one, that might not be a concern to you, to the doctor, or to the lab. That just could be due to artifact. But if I look at sickle cells at one, then that means it's telling the doctor this is very important information. Generally, you should also call what you see, and this will take time, practice, and confidence, which will hopefully your institution will help you build up on. Also, again, use that CBC to help you call what you see. If you're not sure if your cells look different than one another, then check back at the RDW real quick. Or if you're not sure whether or not your cells are really small or really big, then you could look at the MCV. All right. This is a fun part. RBCs don't normally have any particular inclusions. The inclusion that they may have might lead you to thinking about certain disease states when you're present, and it can also even help just differentiate anemias from one another. So basophilic stippling, this is my favorite thing. So you'll see these like very small specks throughout the entire cell. It's they can vary, but they're usually very small. This is all just ribosomes and RNA, and this is strongly associated with lead poisoning. You can also see it with any anemia is associated with abnormal hemoglobin synthesis or thalassemia. Cabot rings. I haven't found this one yet. There are these little inclusions that look like a figure eight or an oval ring. They're thought to be the remnants of spindle fibers, but I believe research is still out on that. But they're usually associated with severe anemias and dyserythropoiesis, or you're just not making red cells right. Howell Jolly bodies. These are just really dark circular granules, and you only see ever one, and they're usually DNA fragments. You can see it in RBCs, but rarely there's only one. There's usually there's never more than two. I think I've only ever seen two once. They're seen in postsplenectomies, megaloblastic anemias, hemolytic anemias, or severe anemias. Heinz bodies, and this is what I have to fight my lab techs with sometimes. Heinz bodies, you can't call them if you think you're seeing them on the right stains. They're only called Howell Jolly bodies. So you can only see Heinz bodies with a supervital stain, and they'll just look like these weird inclusions that are just on the outside of the cell membrane. And this is composed of denatured hemoglobin. So this is usually seen in G6PD deficiencies, any unstable hemoglobins, oxidizing drugs or toxins, and post-splenectomies. And this is strongly associated with any sort of shunt deficiency. Pappenheimer bodies. They are made up of these damaged secondary lysosomes and mitochondria, and they'll appear as like small granules in your RBCs and erythroblasts. You can see them in both Wright stains and Prussian blue. Romanowski's will stain that protein that's found in the Pappenheimer bodies, and Pearl's Prussian blue will stain the iron. You'll see these in sideroblastic anemias, thalassemias, or severe anemias. And this is what Pappenheimer looks like. I actually had an encounter with this the other day, where me and another tech thought that this might have been bacteria, but we checked on the patient's chart and they had severe hemolytic anemia, and so we changed our conclusion from um, bacteria to Pappenheimer bodies. And you can see that it shows up in both. Any iron inclusions that you will see. Um, so sometimes if a patient is having a really rough time, you can see iron condensing into these crystals. Um, so siderid So these are usually a side product from when iron hasn't been incorporated into the hemoglobin yet. Sideroblast just means that you're seeing it in nucleated cells. Siderocytes means that you're seeing the iron in non-nucleated cells. Both can be stained with Prussian blue, and usually all erythroblasts will contain iron in about 20 to 60%, but you can see this percentage increasing or decreasing. So these are all the conclusion. These are the inclusions that we're looking at. So I just want to point out the siderocytes and the sideroblasts there. So this is just sort of a summary of what the terminology that you're going to be using. Variations in hemoglobin. So again, you're looking at an MCH of about 30 picograms, but usually you'll use MCHC. Again, the normal pallor is about 1/3. Hyperchromic means that I have a less central pallor, and that means I have more hemoglobin than normal, especially in relationship to size. And hypochromia, which means that the red cells contain less hemoglobin than normal. And the central pallor is greater than 1/3 of the diameter of the RBC. And MCHC will usually be decreased. So this is a microcytic hyperchromic smear, and the reason that I'm using that terminology is because I'm noticing the central pallor is greatly increased in the cell, and that the cells are generally a lot smaller than the lymphocytes seen on screen there. You can also call polychromasia, and I've sort of emphasized this to my students. You can't really call them reticulocytes technically, so most hospitals report it out as polychromasia. And they'll show up as this bluish tinge, and that bluish tinge is caused by the residual RNA. If you see a large number of reticulocytes in your smear, then it's sort of a coping mechanism from your body. Basically, you have less RBCs that are surviving, as well as a greater hemorrhage. So, this is sort of a good step-by-step way of thinking about manual differentials, and I sort of struggled to simplify this. But if you have, so first thing you're going to do is make sure that the white total count is accurate. I'm going to look at the histogram and the scatter plot, and I'm going to see how well that degree of separation is in between the populations. If the computer can't accurately determine it, or if I think that the scattergram doesn't look good, then I'm going to want to try to do a manual differential. If I believe that any sort of nucleated reds are interfering with it as well, then I'm going to see if I need to correct it. I'm going to compare the white count with the reference interval that my lab has, just to sort of see if I'm working with decreased or increased. Then what I'm going to do is I'm going to see if you have you should have an automated diff. I could see generally what I'm looking at, but right before I do my manual differentials. So as I'm doing my manual differentials, I'm keeping in mind what the automated differential says, and sort of what I'm seeing on the smear. If I'm noticing any immature cells, then I need to report them out as I need to. Especially blasts, that's a big one that you need to make sure that you're not missing. And last but not least is if I'm able to notice any sort of abnormalities or inclusions, then I'm going to see if that matches up with what I'm looking at number-wise. RBCs, I again sort of struggled with simplifying this, but all I'm really doing is I'm just looking and comparing between what I see on my peripheral smear to what I see on the CBC. If I'm looking at the MCV, then it should match whether or not I'm calling it macro, normal, or micro. Um, if I'm calling it hypochromic or hyperchromic, then I'm gonna make sure that my MCHC says the same thing. Again, RDW is used to help figure out if there's a large variation, and then I can also then start describing any abnormal morphologies that I'm describing. Any remaining information just generally means looking at the patient's chart, seeing what they're in for in the first place, and that might also help me make an informed decision as to what I call. So, platelets. I'm just going to see what the total platelet count looks like. I'm also going to see what the MPV is, and that way I can call the morphology of the platelet and see whether or not it matches with the numerical values. A lot of labs will allow you to just very quickly look at the number of platelets per RBC and tell you, say if I could call it increased, adequate, or decreased. So these are just the optimal smear characteristics written out for you. These are again what I'm just looking for as I'm thinking about my smear. And this is sort of what I'm looking at as I'm going through. So, as a lab professional, right, this is sort of your job to understand what you're reporting out and how that can impact patient care. I'm not necessarily saying that you need to be the one to come up with the diagnosis, but you need to understand what you are saying in order to help reaffirm the doctor's belief in the values. My job is to make sure that I'm seeing any abnormal results. If I'm seeing anything that's sort of weird or pathologic, that I should be able to help recommend any follow-up testing or reflex testing. If I need to recommend that a pathologist needs to look into the smear as well, especially if it looks too complicated. Delta checks is something that the lab looks at. I don't believe doctors look at too much. Basically, it just describes a great change over the previous 24 hours. And what that helps me do is help aid in any identifying errors. And this is really important in diagnosis because let's say I have a delta check where my platelet count is severely decreased and the patient's completely asymptomatic, then somebody's going to freak out. And I don't want to cause unnecessary panic, especially as a lab tech. So this is just sort of something overall that you're going to look at. So the LIS, it's just basically the information system that the laboratory uses. It'll also, which its job is to help report out the values that you're calling from the instrument. It'll also usually include reference intervals for each test that is on there, and it'll also help flag for any abnormal results. This is sort of something that is also important for lab techs. Critical limits, aka panic values, just basically indicates that you have a value that needs to be immediately looked at. By CAP, you have to confirm and document and call it directly to the physician because of how important it is that the physician looks at it. Um, and this is sort of, if you're working in pediatrics, this is something to keep in mind. Adults are very good at looking regular, for lack of a better term, but kids are a little weird. So you'll notice in newborns the white count is higher because their immune system is developing. They'll have a large amount of granulocytes at first, but then they usually drop back down. And you'll also see more immature white cells. Um, they might look like blasts. Don't freak out. They're just immature. The RBCs will usually be macrocytic, as well as the reticulocyte being a lot more increased, and you could also see a higher number of nucleated reds. In kids, lymphs will be your predominant cell until you turn 4, and about that, after that, you'll have a more normal adult-looking subset reference range. In the elderly, sort of the issue is as your body ages, you sort of become more prevalent to disease. So the bone marrow cellularity will start to decrease, And your anemias can start rising because of a lot of different issues, but generally they're due to you aging. You can also see malignancies happening at a higher incidence because, well, it's complicated. This is also sort of something to keep in mind. You have to talk about the demographic that you're serving. Assuming that you're in the States, you're going to be dealing with a wide variety of populations. So, for example, we have a high African American or Black population in the States. That's usually associated, and they usually have a lower hemoglobin, hematocrit, and MCV than Caucasians or white people do. And they have a larger presence of, I want to say, just generalizing to hemoglobinopathies as well. Um, there's sort of a uh, there's sort of a good point in talking about how the biases of doctors might cause a misdiagnosis, but unfortunately, we don't have time for that in this lecture. Just understand that some populations are much more prevalent to certain diseases. White counts will also be particularly lower, especially your granulocytes, and lymphocytes will be higher instead. Between the two sexes, they're also different. So males will usually have a higher hemoglobin, hematocrit, RBC, and white count. Females will usually have higher platelets and slightly slower MCV and MCHC. And even then, your geographic location will cause it too. So generally, your hemoglobin, hematocrit, and RBC will be higher for anybody living at any high altitudes. And sort of the talking about these variations is a key point in talking about establishing reference ranges and sort of understanding the patient population that your laboratory might be working with. And it's a good discussion to have if you're able to have it. And that is the end of today's lecture.